Okay, so if we could just settle down the room a bit. Thank you. Good evening. And welcome everyone. Everyone is so good. I'm so happy to see you all. We're pleased that you're joining us for our 2026 Community Conversation Food Cancer Series. I'm Von Brown Miller, with the Office of Outreach and Engagement with Karmanos Cancer Institute. And I'm excited to open up this program this evening. This is an important gathering for us of our community as we bring community and science together to share and to listen to one another. The purpose of this series is to connect our community with the science and our science with our community. These conversations are a space to share knowledge, listen deeply, and build a strong connection between research, providers, and the people they serve. After your participation in this event, if you would like to learn more about getting involved or connecting with the community and science, I encourage you to stop at our COE table right in the back on my left-hand side to get some more information. We are proud to be partnering with the main library, the Detroit Main Library. This is a beautiful room for this series. And we'd like to thank Brian Vance, Andrea Thomas, and the staff that helps to put this room together for us every month. We also would like to acknowledge our RAC partners. That's our research, advocacy, and consortium partners. The American Cancer Society, Blood Cancer United, Gilda's Club of Metro Detroit, the National Council of Negro Women, Detroit Section, the Pink Fund, Pro Literacy Detroit, Sisters Network of Greater Metropolitan Detroit, Western and Wayne Family Center, Detroit Parent Network, and Healthier Black Elders. Will you all just give our RAP partners? We're grateful to Global LT for providing translation services in both Arabic and Spanish. And if you, that is not me. If you are joining us online, you can select your preferred language by clicking the interpretation option at the bottom of your Zoom screen. I have a couple of housekeeping notes for you. Okay. Oh, I don't know. If you're on with our online audience and you have questions during the presentation, please use the QA feature in Zoom. For those attending in person, kindly hold your questions until the Q&A section, and we'll answer those questions at that time. Please note that we're recording this event to help us share and expand the impact of our conversation. Also, for those in person, the restrooms are on the first floor. Guys, take the elevator down to the first floor and then toward the front of the building. Finally, we want to do a special shout out to Emmanuel House of Prayer. They're viewing this event as a watch party. And so we're happy to have them, and we want to thank Pastor Cornelius Sims for that opportunity for his parishioners. Y'all can give them a quick hand, you can. I would like to acknowledge and thank our speakers and my friend, Dr. Lauren Hamel, for joining us tonight. Community moderators for this evening is Megan Landry from the American Cancer Society, Rosalind Sample from Pink Fund, and Robert Thomas from the Black Men's Cancer Action Council. They will guide us through this important conversation this evening. I will hand the program over to our moderators to introduce themselves and get us started.
Hi, everyone. My name is Megan Landry, and first and foremost, I'm here as a cancer advocate and caregiver. Like so many people in this room, my commitment to this work is deeply personal and shaped by supporting loved ones through diagnosis, treatment, and survivorship. Those experiences are what continue to ground me in the urgency and humanity behind everything we do. In 2018, I lost my dad to cancer, and during his journey, I was one of his primary caregivers. Walking alongside him through diagnosis, treatment, and ultimately the loss profoundly shaped who I am. In my professional role, I'm the Associate Director of Cancer Center Partnerships at the American Cancer Society. I have the privilege of working closely with institutions like Karmanos Cancer Institute to strengthen collaboration across research, patient care, community engagement, and advocacy. My work is focused on aligning American Cancer Society resources with the exceptional expertise at Karmanos so that together we can reduce cancer disparities, expand access to care, and improve outcomes for patients and families across Michigan. It's really an honor to partner with Karmanos to be part of the meaningful impact happening here.
Good evening, everyone. My name is Robert Thomas. I'm from here, I'm from Detroit. How I got involved with CAC is that I didn't grow up in the normal environment. I grew up in the foster kid. So I didn't know my biological mother and father until later in life. But when I did, they were transitioning away. Both of them had mother passed. So my mother transitioned from cancer, and my dad transitioned from prostate cancer. And after asking around, a couple of my uncles actually told me that, hey, you have probably about 6 or 7 other aunts and uncles that have transitioned from cancer as well. So I just thought upon myself that, hey, I may need to look at this because I may be next in line to have to face this type of battle. And financially, I may be in that position to fight off some of the things that come up with cancer, but my parents did not, my biological parents. But that's why I involved myself, and to this day, we're in the Black Male Cancer Action Council, and we meet monthly. Just about monthly. Once it's off again. So we meet about monthly, and we go over and talk to one another about cancer and what we did for a month, and keep up with each other. And not just that, we put on programming around prostate cancer and other types of cancers that affect African American males and the general population. Thank you.
Good evening, everyone. Oh, wow. Good evening, everyone. If you know me, you know I love them, Mike. But good evening, everyone. I am Rosalind Sample from Pink Fund. I am the community outreach coordinator. Pink Fund pays non-medical bills for breast cancer patients who are going through treatment, who've experienced some loss of working income. I have resources on the Pink Fund table back there. Some of you got some t-shirts, but there are lots of resources, and that is my passion, is connecting people to resources and making sure that they have what they need, even outside of the work that Pink Fund does. I have been a caregiver since birth. My mom passed 2 years ago, but most of that journey was her advocating for herself, me learning how to advocate for her. And then towards the end of her life, really being her advocate. So it's important to me, the subject that we're going over today, because I've had many conversations with lots of providers, and I know that we're going to get some good information from Dr. Hamel today. But before we dive into today's topic, let's start with a few quick questions to see what we already know or think we know about this subject. So don't worry, it's not a test. It won't be graded. Well, it is a test, but it won't be graded. It's just a way for us to reflect on our current understanding and get us thinking. This will help us connect what we are about to learn with what we already understand. For those of you joining us, let me show you, it's the pink sheet here. So this is the sheet that you want to take out and complete. For those of you joining us in person, you should have this in the packet when you arrive. There's a pink sheet of paper labeled pre-knowledge questions on top with 3 short questions. Please take a moment now to complete that sheet. When you're, upon completion, please tear off this sheet from the attachment, and team members will be going around collecting them. There's about a still and video. For our participants who are joining us by Zoom, hey y'all, a poll will be launching on your screen in just a moment with the same 3 questions. So please take a minute to answer them using your device. All right, so the questions are, number 1,
It's gotta be.
everyone
I'm looking at your
has advised
level now.
even doctors and other healthcare providers
It should be,
select only one answer.
because I've got you guys
Off
right
the sheet.
directly in the Zoom and then out.
And then number 2, implicit biases can influence healthcare providers' communication and decisions, but not always.
I'll keep working on it.
Select only one
But,
answer.
right?
True, off, or not sure. And then the third question is, which of the following is a part of patient active participation in their communication with their healthcare providers? Is it patients asking questions, patients stating preferences, patients expressing concerns, or all of the above? So once you're done answering those questions, go ahead and hand those in to Von Seal and Danielle. Thank you. Need the mic.
Okay, so I have the honor and privilege of introducing Dr. Hamel tonight. Dr. Hamel is an associate professor of oncology and co-program leader of the Population Studies program at the Karmanos Cancer Institute and Wayne State University School of Medicine in Detroit. She is also the faculty director of the Karmanos Cancer Institute Medical Interaction Research Archive. Dr. Hamel is an expert in patient-provider communication, cancer treatment disparities, and in building and testing interventions to improve patient-physician communication. Currently, Dr. Hamel is a PI of an American Cancer Society Research Scholar Health Equity Grant, testing the effectiveness of a patient-focused intervention on patient-clinician treatment cost discussions and other patient financial toxicity-related outcomes. She has over 50 publications, including articles in peer-reviewed scientific journals, including Cancer, the Journal of Clinical Oncology, JCO Oncology Practice, and Cancer Control. Welcome, Dr. Hamel.
Thanks, Megan. Good evening, everyone. Thank you so much for having me tonight. I'm glad to be back. I was able to join you all about 6 months ago. I'm happy to report that the sun is shining brighter than it was that evening in November. And I'm keeping an eye on the time because I'm well aware that game 2 starts at 7. So we're going to hope for a better outcome on this one. So as Megan mentioned, my name's Lauren. I'm a faculty member in the School of Medicine at Wayne State. And I'd just like to put up a little bit about me. I serve as an associate professor in our Department of Oncology. I spend most of my time studying doctor-patient communication and disparities within that communication. I also serve as a leader of our population studies research program in the Karmanos Cancer Institute. And all of that is really focusing kind of our entire faculty on research issues related to disparities in cancer care, from screening into survivorship. I study, as I mentioned, doctor-patient communication with a focus in healthcare disparities with a focus on race, and also in building and testing interventions. I also, neglected to include in my bio is that just in the last couple of weeks, Dr. Thompson, myself, and a few of our colleagues were awarded a really large center grant from the American Cancer Society. And within that, I have a project that's solely devoted to implicit bias and really expanding the science even farther, which is really exciting. And the last thing, too, I'd just like to include that I am a three-dimensional human, and I spend time with my friends and my family and my boyfriend. I spend a lot of time taking care of my fur babies. You'll see them there, and trying to get out and run for exercise when I can. So today, I just want to cover, what we're going to talk about. I got kind of 5 big things that I want to review with you all. The first is just a real quick kind of health disparities primer, what we mean when we talk about disparities. I'm going to talk very briefly about how science and research more generally has identified patient and physician attitudes as contributors to health disparities and the communication between them. But really what we're here to focus on is one attitude in particular, and that's implicit bias. So I'm going to talk about attitudes kind of generally and then delve down really specifically on what implicit bias is, with a focus on the definition and how it's measured, because I think those 2 pieces of information are really critical. I think implicit bias gets talked about in ways that I think aren't as precise as I wish they were, so I'm hoping to put some precision around that. And then spend a lot of time talking about the science that's examined implicit bias and what we've learned, to be able to identify how levels of implicit bias affect the way people communicate, including how physicians communicate, and what that can mean for communication, but also outcomes for patients, and especially patients identifying as Black and African American. And then the last piece, of course, is once we identify the problem, what are we going to do about it? So what are evidence-based strategies that if you're a patient tomorrow morning, what can you do in an exam room to help ensure that you get higher quality care? So to start, like I mentioned, I wanted to describe a little bit about what motivates this kind of work. And really it's and I'm sure I'm not telling anyone in this room anything new, but it's the persistent disparities that we see in the healthcare system of our country. And we see this across conditions, across disease type, but especially we see it in cancer. So I just kind of want to show you a little graph here. This was published earlier this year. This group of scholars always give an update annually of cancer incidence and mortality rates across the country. And what you'll see there is we have it broken down into kind of 5 big racial groups. And if you look at just the blue bars, these are levels of incidence, so diagnoses of cancer. We actually see that as a group, Black and African American people have a slightly lower incidence rate compared to white people, and American Indian and Alaskan Natives. But if you look closer at mortality rates, so death, we actually see an increase compared to white patients, and a little bit of a decrease compared to American Indian and Alaskan Natives. But what you'd expect to see, kind of statistically, is that pattern kind of continue, right? So if one group has a higher incidence rate, you'd likely see a higher mortality rate. But we see the reverse when we look at Black patients compared to white patients. Now, to kind of delve into a little bit more precision, what they report in these findings is that if you kind of break it down by gender, Black women are actually 12% more likely to die from their cancer compared to white women. Now that's across cancer types. But if you look really closely at breast cancer, what you see is a really striking disparity in which Black women actually have a 4% lower breast cancer incidence rate compared to white women, but a 41% higher mortality rate. So slightly less likely to be diagnosed with breast cancer, but far more likely to die from it. And we see the same pattern for men, where Black men are about 19% more likely to die from their cancer compared to white men. Now, as you can imagine, a lot of things go into these disparities. But where my work has found itself is really the result of a panel, an Institute of Medicine panel that came out about almost 25 years ago. And this was a large group of medical experts across the country, again, across disease type. It wasn't exclusive to cancer. But this was the first time where the examination of disparities also examined things like attitudes, so the attitudes that patient and providers bring into the interaction with them. So the first time a really high-level publication identified healthcare provider prejudice or bias. They also include minority patient mistrust and refusal, which is another piece of research. I'm happy to come back to talk about that, but I think given the time limit we have tonight, I really wanted to focus on that implicit bias part of the provider. So if you look at kind of a high level, contributors to disparities, we see a lot of things. Of course, there's differences in tumor biology, differences in socioeconomic status, access to and quality of care, the environment we're all raised in. But the work that I'm reporting on tonight focused on those two other contributors, which are the attitudes and the communication that occurs between patients and providers. So this work, I feel very fortunate, that saying, being able to stand on the shoulders of giants. I've been able to kind of come in, after a few decades worth of really solid, research and science to be able to extend this work. And a lot of this foundational work, we are examining attitudes and communication for patients from different racial groups, was very descriptive. There wasn't, kind of like predictive frameworks put around it yet. It was a lot of self-report data, asking patients of different racial groups what their communication experiences were like with their providers. There's been scientists like myself who have benefited from providers allowing us to actually video record them with their patients. So as those of you who I've worked with in the past know, I have some really strong collaborations with our oncologists at Karmanos where they actually let me and my team put GoPro cameras in the exam room and record them, talking with their patients, both black and white. And then my team and I are able to systematically analyze those interactions to determine what differences are there, if any, and then work backward to figure out kind of where they stem from. But this slide is a big summary of the work that kind of came before me, where we were just looking at communication when you have groups of black patients compared to communication with groups of white patients. Now these are averages, so it doesn't mean it happens this way all of the time. But what we were finding is that we saw some really stark and persistent disparities in the communication black patients were experiencing compared to white patients. So on the physician side, we would see that physicians, when communicating with their black patients compared to white patients, were providing less information, were less patient-centered in their communication, were more verbally dominant and more contentious. And on the patient side, we were seeing that black patients compared to white patients are asking fewer questions, participating less in their decision-making, and leaving their exams with reduced understanding of diagnosis and treatment compared to white patients. And on balance, we saw that these visits were generally shorter. So we would have, just looking at pure time, that interactions with black patients were shorter than interactions with white patients. So we don't really know what's causing this yet, right? We just have some descriptive data showing a persistent and troubling pattern. Now, as I transition into kind of the meat of this talk, which is implicit bias, I'd love it if you would humor me with a riddle. You may have encountered this before. I didn't make this up. It was around long before me, but I hope what it does is kind of convey what implicit biases are. So to start, a father and a son are in a horrible car crash that kills the father. The son is rushed to the hospital, and the doctor declines to attend to the patient because that boy is my son. We've got an answer up here. That was really quick. I'm hoping not everyone heard her. Any other answers? Asking kind of the answer to this riddle. A father and a son are in a horrible car crash that kills the father. The son is rushed to the hospital and the doctor declines to attend to the patient because that boy is my son. All right, cool. You all got it. The answer to the riddle is it's the boy's mother. It's a physician, is a woman. But you'd be very surprised that, and Von Steele's laughing because Von Steele and our moderators generously did a dry run with me on these slides the other day. And I'm thrilled to announce that riddle worked really well and that they all got stuck. They all took some time to figure out, like, what are you trying to ask me? What is this that you want? I have I've presented this riddle to a lot of different audiences. What I have found that when I present this to students, it usually takes them a little bit longer. I've had some great answers. I've had one student suggest to me that the dead father returned as a ghost to attend to his boy. I've had another suggest that it was a gay couple, so two men. Okay, all right, good call. But I think what this is trying to kind of illustrate is that a ghost doctor came to mind before a woman doctor. And we are all in this room know very well women can be physicians, right? Maybe a few of you are female physicians. Maybe you know female physicians. Maybe you're treated by female physicians. But what implicit biases are is that kind of initial or gut reaction to what we kind of pair in terms of different professions, in terms of who's qualified, in terms of who's knowledgeable, in terms of who can do different things. And that can be gender, it can be race, it can be age, it can be ethnicity, it can be political orientation, it can be, religious background. And, it doesn't, I'll kind of get into the data a little bit more, but it's more than just kind of, I had to think about that for a little bit. What the data I'm going to show you demonstrate is that these kinds of gut reactions can have a real impact on our communication and how we react to one another. And so, in fact, about 80% of people who see this riddle for the first time can't give that right answer, that the doctor is the boy's mother. And what it's trying to demonstrate is that implicit biases are really associations. It's kind of what we associate with what. So men are physicians, women are nurses, is what we're trying to get at. Even though we know men can be nurses and we know women can be physicians, we know that. But what the kind of area in the study of implicit bias does is examine how strong those associations are. And this, I'm not going to get into each of these because I know we're limited on time, but I always like to provide these kind of follow-up tools and books if people are interested in learning more. And to understand really that the definition of implicit bias is an unconscious attitude, something that we're not aware of, something that kind of operates outside of our awareness. It's that automatic association for things. And we hold that about groups of people, and that science has shown can affect our understanding, our actions, and decisions about members of those groups. So if you have some extra reading time, I'd highly recommend Thinking Fast and Slow by Daniel Kahneman and Blind Spot by Drs. Banaji and Greenwald. And has anyone here ever taken an implicit bias test? Okay, great. If you have 10 minutes, I would go to Project Implicit. It's housed at Harvard University's website. It takes 10 minutes, and it gives a great description of what gets tested when you're testing implicit bias. And here I've got a screen grab of one of those tests. And you can take it for a number of topics. You can take it for gender, you can take it for age, you can take it from different racial groups. But what it is it asks the test taker, it kind of presents the test taker with two pictures and with a series of kind of negatively and positively valenced words. And it's the quickness or the speed with which you connect certain faces with certain words. So it isn't about kind of a conscious decision. It's not saying like this type of person is good or this type of person is bad. It's that automatic association that we have. And if you take too long, the test will kind of throw a bit of an error. Like you can't sit there and think about it. You have to be able to do it, because it wants to see how strong that association is. And what it gives you is kind of where you are in a continuum. Are your associations really strongly this way? Are they really strongly this way? Or are they kind of somewhere in the middle? So it's a bit of a sliding scale. And now that's one part of it, right? Whether or not that affects your behavior is another story. But to kind of just give you a sense of how this science has been broken down, the way that scholars have envisioned this is kind of the dual process models of human thinking. So we have our implicit processing and our explicit processing. That implicit is that really low effort, automatic, not logical, not purposeful. Our thoughts and our feelings are automatically activated. They're difficult to control, and they're usually nonverbal. Has anyone in this room ever been accused of having an expressive face? Yes. Yes, when I was a little girl, my mom told me that if I didn't stop rolling my eyes, they would get stuck there, And it's that kind of reaction, like not even be really sure that you're doing it. And then on the other side is explicit processing, really high effort, logical, purposeful, consciously activated, and these manifestations are much easier to control, and they're usually verbal. And what I'm not trying to do here is to pit these next to each other as good versus bad, because automatic processing is what allows us to build as humans. You know, think back to when you were younger and learning the skills that you take for granted today. Like remember, this is a long time ago, but tying our shoes. When you have the two loops and you loop them together, and like that takes effort to get your hands to do the thing that you want to do. Learning how to drive a car, you know, it takes a lot of effort to know how to, you know, switch lanes and get the car into gear. And now we do those things without thinking. So it's not that implicit processing is bad, it allows us to build. But what becomes problematic is when implicit processes take over in situations where our kind of higher order brain really needs to be in the driver's seat. And research has shown us that race-related thoughts and feelings operate at both implicit and explicit levels, but implicit bias is often the better predictor of discriminatory behavior, which is why this area of science has really, pardon me.
Sorry, we're going to take a 30-second pause to allow our interpreters online to transition. Interpreters, please transition now.
Yeah. So this work around implicit bias has taken a lot of different directions. What we know from, again, decades of work is that implicit biases are pervasive and robust. We all have them. We all have them on that sliding scale, even those of us that have these avowed commitments to impartiality. We know that they're related but distinct from our explicit biases. They don't necessarily align with our declared beliefs. And what they really tend to do is favor our in-group more than kind of disfavor our out-group. It's, I think, about being more favorable of what's familiar to us, whatever that group is, whether it's gender, race, age, et cetera, et cetera. But we do know that they have real-world effects on our behavior. What we've also learned across many, many studies is that there are features of our environment, enhancing factors that can cause implicit biases to have a greater effect on our communication and decision making. And these include having a heavy workload, having incomplete information, and a need for quick decisions. So, okay, that's all of us, right? That's all of our lives. But when you think about certain professions, healthcare providers kind of pop to the top of that list. A lot of this work has gone into different areas, including law enforcement, so this is why I include public defenders and police officers. We're here today to talk about health and healthcare. But if you think about healthcare providers who are inundated with work, they don't have all the information that they need, and they have to make decisions really, really quickly for their patients. So that kind of environment is really ripe for implicit biases to kick in, because we're all kind of functioning on autopilot. There's things that we can do about it, but it does mean that our environments kind of set us up for this. Now, in terms, if we drill it down really specifically to physicians and healthcare providers, what we know is at the explicit level, physicians consistently denounce overt racial bias. A national survey that was conducted a number of years ago reported that 88% of respondents said that they give better care to their Black patients than their white patients. More recently, a systematic review was published. This included 44 separate studies that examine implicit bias in healthcare providers. 35 of those 44 studies found evidence of implicit bias in healthcare providers. And all of the studies that investigated relationships with implicit bias and lower quality care found that. They found a significant relationship between higher levels of implicit bias and lower levels of quality of care. And we know that healthcare providers have levels of implicit biases similar to the rest of us. So just because you're a physician or a nurse or something like that doesn't mean that you are excluded from this phenomenon. Now, a lot of the work that has examined really specifically the communication behavior around this has come from Wayne State and from the Karmanos Cancer Institute. So I worked really closely with a former mentor of mine on a lot of this. Many of you may have encountered Dr. Lewis Penner in previous sessions. But what he did was build on this work and use those video recordings, use those audio recordings with physicians who we also were able to assess their levels of implicit bias. So they took an implicit bias test for us, and then we were able to collect a number of interactions with them and their patients. And what we found was physicians with higher levels of implicit bias favoring white people had some consistent trends. First, we saw that they had shorter treatment discussions with their Black patients. We also found that they were less patient-centered and less supportive in their communication with their Black patients. Their patients, on the other hand, reported greater difficulty remembering contents of the interaction, and that indirectly led to reduced confidence in recommended treatments and greater perceived difficulty completing treatments. These physicians also perceived that their Black patients were less trustworthy, less educated, and less likely to adhere to medical treatment. And the last piece I want to draw out here is they were perceived by their Black patients as less patient-centered and trustworthy. Implicit bias is by definition operating outside of our awareness, right? So the physicians themselves may not be aware, but it affects their behavior to the extent that people that they're communicating with notice it. Maybe they don't call it exactly what it is, and these are relationships that have no history. These are brand new patients. So it's not even as though you have a lot of time to collect information. These are 20, 30, 35-minute interactions. And patients are able to say, there's something not right here. Now, these data are striking, in my opinion. And so what do you do once you find out that there's a problem? Now, in our conversation the other day with the moderators, to be honest, more effort has gone into working to train providers, but I think we've benefited from a lot of literature that's gone into examining what patients can do, right? We can't fix everything, we can't fix everybody else, but we can, what do we have control over? Our own behaviors, right? So a few years ago, a group of scholars, some of which we've worked with previously at the University of Michigan, published a paper about how important patient activation is. And we're going to talk about what that is next, but how that can reduce the effects of implicit bias on doctor-patient interactions. So what is patient active participation? Participating actively in a doctor's appointment has major benefits for patients, including reducing the effects of implicit bias. So what do we mean when we talk about active participation? Well, there's like 3 big behaviors, right? There's asking questions. So when you're with your physician or other providers, things like, will this treatment cure me? Will I lose my hair? Is a clinical trial available? Stating your preferences. Maintaining my independence is important to me. Expressing your concerns. I'm worried that I won't be able to afford my care. This kind of verbal activity can do a lot for patients for a number of ways, including reducing the effect of implicit bias. Now, research has shown us that there's 2 important strategies that can strongly support patient active participation. The first is prepping those questions, preferences, and concerns ahead of time. Writing them down on a piece of paper or having a note in your smartphone and bringing them to your appointment with you. That way you don't have to rely on your brain to remember all of the things that you thought were important yesterday. You're in a new environment, a lot of things are coming at you, you're in the moment. I mean, I know I forget, so having that kind of prompt there can be hugely helpful. The second thing is bringing a support person with you who's also aware of your questions, preferences, and concerns. That means you've got twice as many mouths and twice as many ears, to ask the questions, state the concerns, and to state the preferences, and then to be able to hear the information. And even designating that person to be the note taker. So you, the patient, can be there in the moment, communicating back and forth with the provider, and you have a trusted person that's able to kind of take notes and record what's going on in the moment. One tool that my team and I spent a lot of time developing and testing, in fact, Von Seal and I were working on a project just last night with our young survivors on how to create what we call a question prompt list. And it's as simple as it sounds. Lists of questions that patients may consider asking their provider that they have before the visit. These have been developed and tested in a number of medical contexts, including cancer, populations, countries, and languages. Things around treatment, genetic testing, end-of-life care, financial burden, clinical trials, a whole host of topics. And we have found these to be acceptable and effective in several Michigan and Detroit-based trials. So these real simple lists of questions, really simple tools can do a lot of things. We see that they directly improve outcomes by improving patient activation. We see improvements in knowledge, skill, and confidence. We see increases in questions asked, concerns stated, and preferences made. And they indirectly improve some other important outcomes. How much information the providers share. So you as the patient are more active. Your provider is then going to give you more information. There's an improvement in the number and quality of treatments recommended and decisions made, like clinical trials. An increase in the number of topics that are covered while you're with your physician. and also improvements in things like psychosocial and physical outcomes, like knowledge, anxiety, distress, pain, and even blood pressure. And we've developed a number of these. I'm putting up an example here that focused on clinical trial communication and clinical trial invitations. My colleagues and I finished this trial a few years ago. This was led by Dr. Susan Egley. And what you'll see here in this chart is that the patients that are in the purple bars were our usual care patients. They didn't get the question prompt list. Those in the blue bars did. And so you'll see is that there were increases in clinical trial invitations across all patients, but we saw an exceptionally greater increase in patients identifying as Black compared to white. So everyone got more invitations, but there was added benefit for patients at risk for that poor quality communication. Now these were question prompt lists that we built with our teams and tested. You can create your own. You really can sit down and just think, what is it that I want to be able to get from my provider? My team and I have housed all of the question prompt lists that we've created so far on our lab website. This is the Seeker Lab. I think we'll be able to share that if you're interested, but there's a page specifically for tools for patients where you'll get PDFs of the ones that we've tested or are currently testing, just to give you ideas for questions you might want to ask. Doesn't mean you have to ask all 45 of the questions listed, but maybe 3, 4, or 5 if you think that they're important. So I think as I get toward the end, and I know we've got time for some questions, but if I could give you with 3 takeaways from this evening, I think the first is implicit biases can influence communication and decisions, but not always. I presented some data that I find to be particularly striking, but that doesn't mean that that's happening all the time. I mean, there's risk for it, but you're the one that's in the moment, you're the one that's working with your provider, so I don't want all of us to assume that that could be the case all of the time, but there is a risk. Fortunately, we as patients can do something to help mitigate that, which is simply by being an active participant in our interactions. That can then reduce the effects of implicit bias. And evidence-based tools are available to support patient active participation, or you can make your own. That kind of tool, I think, can be very personal and something that you can create with you or close friends and family. So those are my big 3 takeaways. I wanted to leave my contact information and the lab website here, which I'm sure we'll distribute. And I think we're going to pause for some questions, but I'm happy to take anything now, too. So thank you for your time.
Thank you. And we will direct them to Dr. Hamel. If you're in the room, you can raise your hand and the team will go around with the microphone. Oh.
Dr. Hamel, do you think a political, I'm trying to look for the right word. Okay. Do you think that someone's political beliefs impact on their delivery of services, particularly in the climate that we're in now in the United States?
So I think that's an excellent question. I don't have access to data that would allow me to answer that yes or no. But what I will say is that our levels of that kind of association, our implicit biases, those associative attitudes, kind of exist regardless of our political beliefs. And in fact, there's this kind of sub-literature of people who find out that their implicit biases are kind of in direct kind of competition with their explicit biases, and they are what we describe scientifically as aversive racists. They find out that they have this bias, and they have this kind of, I'm not sure what the word is, but just aversive reaction, like, surely no, that can't be true. I'm an egalitarian, I do all of these things, I think this way explicitly. How can this possibly be? So I think I love your smile because I find that to be also a little bit amusing. Not that I want people to feel that way, but but it goes to show you, our brains operate in ways that we can't control. And so an explicit and an implicit attitude can be related, but they don't not necessarily one and the same. So I think, I think your question is a good one. I don't know. I mean, I would wager that providers would probably say explicitly no, but I'm not entirely sure how that is. I think, I had another thought I wanted to share about some of the implicit associations, but just that, I know what I was going to say. What I wasn't able to include in this talk is the work that's come out of cognitive neuroscience and how our brain structures can actually affect the levels of our, kind of the strengths of our associations. So there's certainly the societal piece, but the societal kind of lessons we learn over a lifetime change our brains. And so it can be, these implicit associations that affect us in ways that we're just simply not aware of, partly because of what our brains have become. I know it's wild. The face that you're making is the one that I share.
We
gonna
had a
take a
question
question
come in on
online.
Zoom, which was, what can someone do to reduce their own implicit bias?
Okay, that is a great question. And I guess the answer,
Ma'am, excuse me, the question's coming from online. We'll get you in one moment. Okay.
no, it's a question that a lot of people have, regardless if you're a healthcare provider or not. And the way I think the literature has gone is sort of one of two things. One that we can do in the shorter term and one that takes a lot longer. So in the shorter term, I think creating environments where our implicit biases are less likely to be activated. So if you'll remember the slide where I kind of had the big three kind of enhancing factors, need for quick decisions, incomplete information, and a heavy workload, creating environments where we give ourselves the grace to kind of think things through and to give our time to make decisions, which is easier said than done. I'm not saying that this is an easy task either. But there's the environmental piece. Now, longer term, our implicit biases are built over a lifetime, which means, it'll take a long time to rewire them as well. What I wanted to share tonight, but I wasn't able to, is a really large systematic review done by one of the scholars who kind of created the implicit association test. And he and his team did this excellent review of how different interventions or different, trainings to kind of rewire our implicit biases, how successful they've been. And really the upshot was the more time we spend with people with kind of counter stereotypical realities, the more we're able to rewire. And that's really hard to do. I mean, I shouldn't say it's hard to do. I think we all as humans are very good about keeping ourselves in our bubbles and what's familiar to us, people who might look like us, people who might think like us, but exposing ourselves to people who are different than us is really, I think, the most durable way of going about it. I'm not doing justice to this work, but I'm happy to share those findings so you're able to kind of interrogate it yourself. It's not impossible. It's just that it's a bit of a marathon. There's no silver bullet or a vaccine, as it were.
It'll take time.
Yeah.
I have two questions for you, if you don't mind, please.
Yep.
And they're kind of going back to what you said. One, I wanted to know about how is the economic society, our economic program that's going on right now with this government, is it impacting your program in terms of success and intervention? Secondly, my other question was, have you noticed as a scientist of cancer the increase in number of people who are developing cancer? And have you identified things, what was causing the increase?
So was your first question was about kind of our research program more generally? Yes, so yes. The political way of things has really negatively impacted a lot of us. I think Wayne State and Karmanos have done a really, I think, solid job of keeping things going despite everything. I think, I think we kind of benefit from being an impactful but smaller shop where, you might not be on the radar like Harvard, for instance. So we've been able to keep going, but it has been increasingly difficult to write about what we do. Like, how am I supposed to write a grant about disparities or about race or about racism if I can't use those words? That's been really frustrating, which part of the reason I introed with our new grant is the American Cancer Society is not federal. So they are just like, girl, keep doing what you're doing, and here's some money, which is really excellent. And they, really doubled down. Like, they're like, no, we're not changing. So, I mean, the federal funds continue to be worrisome, but happily, institutes like the American Cancer Society have stepped up, but nobody can compete with the NIH. Like that's the most money in the world. So it has negatively affected. To your second question, in terms of increases in cancer, actually, Ms. Landry here would probably be able to answer that question better than me.
So it probably seems like everybody's getting cancer and the rates are increasing. I would say in certain cancers, yes, but the really good news is that more people are surviving longer from cancer. Less people are dying from cancer. It's becoming more of a chronic illness than a death sentence. So, and you've probably all seen that, yes, people in younger ages are being diagnosed with colorectal cancer, and that is something that is really being studied as to why and how can we stop that from happening. So. I felt myself get on that soapbox. Thank you.
Yeah, I've run into situations where the doctor's been dismissive. If I have a change in my health and I get a comment like, well, you're not so young anymore, or I'm not saying it's all in your head, but maybe it is. So is it best to confront them directly and say something like, well, this is new for me. I realize my age, but it's a new situation. And thank you. Or would it be best to say something like, what other reasons could it be? I mean, how direct do you have to be when you feel somebody is really dismissing you and you don't want to leave feeling frustrated? And the other thing I'm asking about is the role of the supportive person. Is it best for them to just sit and observe, or should they be active and ask questions too?
I think you asked two really great questions. I think in terms of how direct to be, I think I would be as direct as you feel comfortable. I think not that it's fun to do, you don't want to have to shop for a doctor, but you can always find a different doctor, And so if you push them and say, I feel like you're dismissing this, and they don't respond in a way you see fit, you do have choices. I'm not saying it's an easy one, but I would be as direct as you feel comfortable and confident being, because it's a tough thing to say. And in terms of the support person, I think what we've seen is that, having an active support person, like a verbally active support person, is usually beneficial. But that's also the dynamic that you have with them, and how you feel comfortable kind of orchestrating that. So I think some of it has to be a little bit individualized in terms of what you feel comfortable doing. I mean, scientifically, you want them to be active, but there are individual things that you need to take into account.
Two-part question to our presenter. What are some steps that African Americans can take to gain access to clinical trials and studies? For example, Wayne State has a cardiac imaging study that's taking place right now. And the second part, to our gentlemen on the panel, what are some things African American men can do to overcome the, race-based medicine that's faced when we encounter our practitioners?
Let me go first.
You want to go first?
I think asking about clinical trials is a great way to start. What we've learned from work really specific on clinical trial communication is that patients from all racial groups will agree to enroll in clinical trials basically at the same rate, but they have to be asked and they have to be discussed. And so usually it ends up being providers that are not initiating that conversation. So as a patient, if you say, I'm interested in a clinical trial, I don't mean to simplify it, but I think that's a great way to get it going because it identifies you as somebody who's interested and willing to kind of participate that way. I would say as an individual. More generally speaking, too, is looking to institutes like the Karmanos Cancer Institute or other cancer centers or other hospitals that have are kind of integrated into the community truly, and don't just kind of come in and then leave, but people who are actually working within the cancer center, within the hospital, but also members of the community, because that benefits a whole number of health outcomes, including clinical trial discussions and enrollment.
And what was your second question? I'm sorry.
How can African American men overcome the race-based medicine or the explicit or implicit bias that we face when we encounter practitioners? For example, you're being aggressive if you ask too many questions, or you're just trying to be assertive, but you're being hostile, and you're persistent with getting and seeking answers.
All right.
How can African American men overcome
Yeah, well, I'm just an engineer with a law degree. I'm not sure if you want to chime in on that one.
I mean, I was like, I'm glad you're getting this question, not me. It's kind of to the lady in the front here. It's so it becomes a little bit individualized, and how much does your pushback result in what you want, right? And if you're seen as assertive versus are you seen as hostile, and you know. I wish I had like a solid solution. I mean, I think having a partner in the room with you is always helpful because you can work as a team. And I don't mean to say this like it's easy, but if you're in a situation with a physician that you're just like this guy, this gal, they're not listening to me, they're not connecting, you may need to move on. And I hate that because like shopping for a doctor is not something that any of us want to do. But if you really aren't connecting with somebody and they're really not hearing you or seeing you as someone who's aggressive, and it's weird that you're talking about this too, because I had a conversation with a friend of mine just yesterday about something very similar. She had a new physician, and she's like, Lauren, I was getting no eye contact. She was being so dismissive with me. I was telling her about these concerns I had and the medication I'm on, and she was just like, well, that's not what I would prescribe. And my friend's like, well, what would you prescribe? And, listed off some things, and she's like, I didn't get any information about those options. She just kind of listed them. So, in her conversation, we were like, should I find somebody new? And there's not like a really nice prescription, excuse the pun, to kind of fix it. I think it's like figuring out how far you're willing to go in the moment and seeing what the doctor kind of response is. Sometimes it doesn't hurt too to bring in other providers. I think similar to Megan, I helped my dad through cancer diagnosis, treatment, and into his death. And there were a lot of times where I found communicating with his nurse practitioner got us a little bit farther. Not a great answer though. I think it's just one of those. I wish I had something more concrete for you. Robert?
I'm really sorry. We're just getting heated up with the questions, and we really have to take a break right now. Lauren is going to stick around so you can have some additional questions for her. She'll entertain those questions. I think it's good to talk amongst yourselves as well, because there may be some good ideas right within this group. We have people here from Cancer Action Councils, and so, raise your hand, you're part of a Cancer Action Council, so they'll know that there's some people here who have some additional information. Go ahead, Robert.
The polling? Okay. All right. At this point in time, let's take a moment here and reflect on what we learned today. We just have a few quick questions to help us think about the key takeaways from today's sessions. For those of you joining us in person, please take a moment now to complete the green-colored sheet of paper labeled Post-Knowledge Questions. One of our COE team members will be coming around to collect them. And in the interim, for our participants joining by Zoom, a poll will be launched on your screen in just a moment with the same 3 questions. Please take a moment to answer them using your device.
Read the question.
Thank you all for your participation. We will now go through the answers. Number 1, everyone has implicit biases, even doctors and other healthcare providers. That's true. Number 2, implicit bias can influence healthcare providers' communication and decisions, but not always. That again is true. Which of the following is a part of a patient active participation in their communication with their healthcare providers? All of the above is the answer. Thank you. Marcio?
Okay. you have one more sheet, a white sheet, if you would fill that sheet out as well. And that's the overall evaluation of the program. Can we just take a moment and acknowledge and thank Dr. Lauren Hamel for her presentation? So this hour goes by very quickly. And so before we close, I'd like to encourage you to sign up for our mailing list. There is a table right back there that you can sign up for if you're not receiving our newsletters. There's several ways to get involved with our group, our COE, and that is, and if you're interested in learning more about research and getting involved with other researchers and giving your input to research projects, that's what we do. And so please do come back and get more information. If you're joining virtually, you can sign up on the link in the chat. I want to thank all of you for being here tonight, and a special thanks to our moderators, Megan, Rosalind, and Robert Thomas. Please give them a hand. They really did an excellent job. Thanks to our presenter, again, Dr. Laura Hamel. Listen, what she shared with you today, you're not going to unknow it. When you go see your doctor again, you're just going to be different. And you're going to look at them differently. And you're going to ask her different questions. And you're going to make sure that you're properly being taken care of. Did you see I said she? Okay. Our next event is Wednesday, June 17th. Pick up a flyer in the back to learn more about it. Special thanks